Yes, let's start. Thank you very much, first of all, for inviting me, and thank you very, very much for a very kind introduction. I'm very disappointed that I'm not in India now, because I love India. I've been to Hyderabad at the ISPAT conference, and yeah, unfortunately, we have it all online now, but as I heard from the organization committee, maybe you can invite me back again next year when we have the vaccine. I hope so. I look forward to that. Yeah, so I just want to declare no conflict of interest. As mentioned earlier, I'm ISPAT advisory board member, so maybe I would just highlight this. And I'm also a person living with diabetes, so I have many friends living with diabetes, and I represent different organizations of diabetes advocates as well. So my presentation will be combined perspective of a healthcare professional, mental well-being specialist, and the person living with diabetes. So what I will talk about diabetes and how psychological burdensome it could be. I will discuss a few psychological concepts that we have in diabetes care: diabetes distress, depression and anxiety, eating disorders. I will discuss the mental well-being and its effect on diabetes care, and of course how diabetes control can affect our brain development, which is extremely important for all children with diabetes. And of course we will discuss all these aspects that we are all aware of. So how the family issue it is, what challenging times we have in the development phase, the adolescence, the transition to adult services, and of course we'll discuss the role of psychologists in multidisciplinary team. So starting from diabetes, and that it has been introduced earlier by the chairs. Yeah, diabetes is a difficult condition to live with, and it's very normal that it may cause some difficulties and mental difficulties as well, such as depression, fear. People can experience low mood, anxieties, etc. And it doesn't only apply to children, but it also applies to families, to parents, to close people. So the other issue is that when we are seeing a healthcare professional, and when we have this diabetes that is so based on numbers and blood glucose sugar values and hemoglobin A1C, we are constantly under pressure to be perfect. So our glycemia should be perfect. We should do everything perfectly. So we have two aspects that are with us since the diagnosis of diabetes. So yeah, let's talk about diagnosis. So since we know what is happening, it's very normal for everyone to experience very difficult emotions, difficult reactions like anger, sadness, feeling of guilt, depressive symptoms, hopelessness, fear, grief. For many parents, when I talk to parents or when I talk to patients as well, it's some kind of a grief, because my previous life is gone and now I have to start to live a very different life. So for some also there are emotions like motivation or relief, even because we had symptoms, we didn't know what is it. It might have been a lot worse than diabetes. So we all have to acknowledge that it may happen, and these all feelings can constantly be with us during our life with diabetes at some stage. So after diagnosis, we have to learn how to live in this new normal. We have to learn all this new habits. We have to forget about old habits. So we have to be ready for change. And then we have to reorientate, and we have to accept the fact that we have diabetes. I don't like to say that we have to accept diabetes itself, but we have to accept the fact that diabetes is in our life. And the positive side of being diagnosed as a child is that children usually cope better with diagnosis. They cope usually better than their parents. They're a lot more resilient and flexible in accepting the new situation. So this is somehow an advantage. But bearing in mind the fact that diabetes is a very isolating illness. I mean, by isolating that, it's all based on this diabetes self-management. So this is me, a person living with it, and the main decision maker. I have to make all these medical decisions every day, me or my parents if I'm a child. I see a doctor sometimes. These are data from Germany, and in Germany usually a patient after diagnosis will see healthcare professionals for maybe 16 hours maximum. So 4 appointments, 12 hours for diabetes education. But when we see it in the perspective of a whole year, it's still nothing. It's like 0%, because diabetes is based on self-management, and we have to all remember that. And also the burden of diabetes. Yes, there are many memes explaining how it can look like, and they're very popular within the group of people living with it. So what type 1 diabetes management looks like and what it really is. And of course, I smile to hide how completely overwhelmed I am, and we just have to be aware of that, and we have to acknowledge that, and we have to understand the fact that that it is very overwhelming, especially for being a parent of a small child with diabetes, and then actually at any other stage of living with diabetes. So when we talk about diabetes, we have to know that there is a concept of diabetes distress, and diabetes distress is an emotional state where people experience feelings such stress, guilt, or denial that arise from living with diabetes and the burden of self-management. Diabetes distress has also been linked to worse health outcomes. So how it works with diabetes distress, you are just so tired of all these responsibilities coming from this diabetes management. You're so tired of self-management. You're constantly guilty because you cannot meet the recommended HbA1c values. You always have this kind of high blood sugar level. Someone will assess you that you're a bad patient because you're not controlling it. And then it just raises and raises and raises higher distress. And some people experience diabetes distress around, there are some data from the systematic review that I wanted to present here. Around 1/3 of adolescents experience elevated diabetes distress, which is a lot. It means that every 1 of 3 of our patients can experience it, and we have to acknowledge that and help them to solve it. And of course, if we are under distress, it will affect our glycemic control. It will provide low self-efficacy, and it will lead to reduced self-care. So when we are talking about distress, this is actually the slide coming not from diabetes care, but this is how we usually understand stress. So we have stress, which is a positive stress, and we have distress if we have too little stimulation or motivation, and if we have too much. So this is where we can put these pictures that I showed earlier. So if we do too less activities related to diabetes, if our control is really poor, is really bad, if we try to forget that diabetes exists, it means that we are under distress, and it can lead to diabetes burnout. But on the other side, if we are too perfect, and if we think too much of too much about diabetes and about this whole activities, and we just want to be perfect and have this HbA1c under 6 or whatever, it may lead to diabetes burnout easily as well. So that's how we should live with diabetes. We should be not too perfect, but also, of course, consider that we can't do too less to manage it, because it's, of course, unsafe. Okay, then we can move to depression, which is quite common in people with diabetes, and children with diabetes are at slightly elevated risk for psychological difficulties. And when we compare healthy people to patients with diabetes, the difference is quite significant. So 12% versus 3% represented major depressive disorder. And there was one important study, the Search for Diabetes in Youth study, and according to the findings of this research, 14% of youth presented symptoms of mild depression. Nearly 10% presented moderate to severe depression. So it means that 1/4 of the population of adolescents with diabetes had depressive symptoms, and it happened quite often that girls had higher prevalence of depressive symptoms than boys. And how it works in terms of the mental health, it's a vicious cycle, because if you're depressed, you are not motivated to manage your diabetes at all. You're demotivated, you're lethargic, you can have mood swings, you can have low energy, you're indecisive. So it will all affect your diabetes management, and it will all increase your risk of diabetes related complications, severe complications, and of course long-term complications as well. And then if your diabetes is not really well controlled, it affects back again your mental life as well. So it leads to lack of social interaction, lack of exercise, it will lead you to some unhealthy behaviors, etc. And then it all increases the risk of depression as well. So it is a vicious cycle, which is really hard to stop. But we have to acknowledge that it exists, and we have to try to help our patients to deal with it, because it is extremely important for the brain development, and it is extremely important to control diabetes. And if we have such a mental challenge that leads us to poor diabetes control, it may also affect our development in the future. So adults with childhood onset type 1 diabetes have increased cognitive impairment, and we have to be aware of that. We have to be aware that hypoglycemia is not as important in causing long-term brain injury as previously thought. And actually, the higher blood sugar values are more dangerous for the brain development. Diabetes, ketoacidosis, DKA causes greater long-term neurological injury than previously shown. And of course, the circumstances of diagnosis are important in determining long-term brain outcomes, etc., etc. So chronic hyperglycemia, this is something that we have to be concerned about, and mental health issues lead to chronic hyperglycemia because yes, this is more injuries to the brain than previously considered. Now I would like to discuss the most challenging, I'd say, and the most dangerous mental health disorder, eating disorders. You don't get a day off when you've got diabetes. Every day is about blood sugar levels, needles and numbers. When you've got diabetes and an eating disorder, well, that's a lot of numbers dictating your life, from calorie counting to watching the scales. And this is the relation from Becky Rutkin, who had an eating disorder. BBC actually put a lot of attention to highlight this topic in the UK, and I highly recommend you to see the videos, the news about it, because this is quite a new concept, eating disorders, and but it is extremely challenging and dangerous for our patients. Of course, girls are at higher risk of developing into eating disorders, and it's for people who have no diabetes as well. Disordered eating behaviors, actually nearly 40% of adolescent girls presented some type of disordered eating behavior, according to one study. 7% of adolescent girls with type 1 diabetes may meet diagnostic criteria for an eating disorder: anorexia, bulimia, diabolia. And what is diabolia? Diabolia refers to an eating disorder in a person with diabetes, wherein the person purposefully restricts insulin in order to lose weight. So if we see the cycle of diabolia back again, it is very complex and is extremely challenging, because it comes from the negative feelings about weight, shape, and body, like any other eating disorder. Then it affects decreased diabetes self-care and strategic insulin restriction. So people are not delivering insulin purposefully, to have very, very high blood sugars and to lose weight, which is of course very effective and very quick, but it is also very unhealthy, and we are at very, very high risk of developing DKA. And of course, high blood sugars increase the guilt, secrecy, fear, feelings of hopelessness, and it will all lead back again to depression and anxiety. And if we are depressed and if we're anxious, it will all affect the negative feelings about weight, shape, and body, etc., etc., etc. So it's a really another cycle that is very hard to stop. Here, I would like to move to the technology thing, because we usually think of technology in the perspective of I mean, insulin pumps, continuous blood glucose monitoring. We usually think of it as something that can help us to improve diabetes control, and that's great. But we also should consider it as something that can increase the quality of life and can help us to deal with diabetes a bit easier. And this is the study that is extremely important, showing different types of technology affecting blood sugar values. And according to this study, those people who were using CGMs had better HbA1c, and it was also considered as improving the quality of life. So it was not an issue of an insulin pump that has changed people's lives, but the CGM. I suppose that CGM is not very available in India. It is not very available in Poland, but I hope it will be at some stage in the future, because it's extremely important to know what is going on in your body. The issue is, as I mentioned, access. But yeah, there are systematic reviews. There are plenty of evidence suggesting that the technology may improve the quality of life and may improve the family challenges with diabetes as well. And authors of this review reported that increased flexibility of daily life is one of the most important benefits for improving quality of life for children with type 1 diabetes and their parents. However, bear in mind, some kids don't want to have technology. They feel too overwhelmed with that, and we also have to acknowledge that and just respect what they want. I found this picture extremely cute when I found it in the internet. This is a boy who has really loads of support from his parents, as you can see. He's an insulin pump. Their parents have insulin pumps as well. And being a parent of a child with diabetes is a really hard job, because we as parents have to manage diabetes. But then when the child grows up, we have some kind of challenging situation in terms of responsibilities related to diabetes care, and this is what may cause many arguments and issues. That's why adolescence is being treated as the age of puberty is treated as a really challenging. And according to Piaget's stages, developmental stages, and we can of course discuss it in the context of diabetes. We have to be aware that kids in different age groups have different possibilities and different abilities. So when we have young children who are diagnosed with diabetes, of course it's all parents' job, but then children can learn some activities, like this little girl, she's checking her BG. I think the sooner kids are getting independent, the better. Then if we have school-age children which are able to provide some concrete operational stages, they are a bit more independent. They have the ownership of their own diabetes, so we have to support their independence. We have to allow them to make mistakes and make decisions as well. And then when we have kids 12 and older, it's all about the autonomy. And I just wanted to show you the video of myself. This is me when I was 7. Oh, sorry, just to show, I hope it will work. Yes. So this is me. This is my beautiful syringe. So I'm 7, that was my dad. I'm not very concerned. It was just, I was always very into doing things on my own. And it definitely built upon my confidence in diabetes care and in ownership, and it led me to be really autonomous in terms of thinking of diabetes as my own issue. So the sooner parents and the sooner diabetes care team helps children to get independent, the better, because then when we have adolescents and we have this kind of issue that adolescents think that he's or she is a young adult, whereas it's not adult anymore, parents are overwhelmed and they are just tired of controlling diabetes. They're tired of arguments. They're asking them, have you checked your blood sugar? Have you checked your blood sugar? What blood sugar do you have? And then we have arguments because adolescents doesn't want to even reply. They want to independently make mistakes. So it is a challenging time. In the most, like, puberty is actually one of the really most challenging times in diabetes care, and sometimes we just have to be patient, and we just have to support parents and children, and we have to actually treat them independently. And I would like to highly recommend you the chapter guidelines from ASPAT Clinical Practice Consensus Guidelines, which is dedicated to diabetes in adolescents. It's a really great source of information. So adolescence is the transitional phase of development. It imposes unique challenges on the individual with diabetes, the family, and the diabetes care team. Of course, puberty, it must be recognized that healthcare and emotional needs are distinctly different from those of younger children or older adults. And adolescence involves training to become an independent adult and may result in failures and mistakes as well as success. So this is what we have to know about adolescence. And also what we have to know is that adolescents are at much higher risk of developing any mental health issues than any other age group. And this slide is just to show you how different parents and children are in terms of understanding their readiness to move to adult services. So we conducted a transition study with my colleagues from Dublin. We asked the question, we asked both parents and children, and we asked them, are you ready to move to an adult service? Of course, not children, adolescents. And the vast majority of adolescents says, yes, I'm ready to move to an adult service. Do you have any worry to move to adult services? Adolescents, no, I have no worries, whereas parents were very different. Parents replied that no, kids are not ready to move to an adult service, and they have loads of worries. And the transition is another challenge and another psychological challenge, because we're transitioning from being a child and treated as a child from this holistic approach to adult services, which are not very pleasant and patient-centered at all. Another chapter guideline that I would like to highly recommend you to read is the psychological care of children and adolescents with type 1 diabetes. Is another chapter guideline which is a key. And what I would like to highlight here is that it is recommended that mental health professionals should be available to interact not only with patients and families at clinic visits to conduct screening and more complete assessments of psychological functioning, but also to support the diabetes team in the recognition and management of mental health and behavior problems. And all mental and behavioral health specialists should have training in diabetes and its management, which is essential to understand, because diabetes is a challenging illness. So what actually psychologists in a multidisciplinary, what is a psychologist role in a multidisciplinary team? So first is assessment of mental health challenges, counseling parents and carers, psychoeducation, cognitive development, motivation to better self-diabetes management, providing coping skills, educating about coping skills, of course, research, trying to provide holistic approach, support the resilience, and of course, referring to psychiatric specialists in case it really needs psychiatric involvement, like, for example, in eating disorders. So social workers and psychologists should be the part of interdisciplinary team. Psychological problems in young persons or family members should receive support from the diabetes care team and expert attention from mental health specialists. Diabetes care team should receive training in the recognition, identification, and provision of information and counseling on psychosocial problems related to diabetes. And this is just to summarize what I said, and according to the introduction that I had, yes, we have now very challenging time. We have COVID-19 pandemic and mental health. I won't talk too much about this, but there was a systematic review on adolescents, mental health and well-being. It's not about diabetes, it's about adolescents themselves, and actually significant percentage presented depression symptoms according to different studies, and in one study even 43% of adolescents presented depressive symptoms. So bearing in mind the fact that we have pandemic, that we are all under the lockdown, we cannot live our normal life, we have no privacy, we also have diabetes and we have our own challenges related to diabetes, and diabetes itself is so challenging. It might be a really, really, really challenging time for some of our patients. That's why what I would highly recommend you is always to ask, how are you? Are you feeling okay? Do you need any help, not only related to diabetes, but also to mental care? And if you have any tools or advice or psychologists that you could recommend to talk to, please do so, because for many it might be a really, really challenging time. So do not forget about psychological burden that diabetes may cause, and pandemic, of course, about exhausted and overwhelmed parents and family members. Try to get them technology suitable for the remote care, because I'm confident you discussed that it's much easier to provide the remote care when you have technology if you don't have. And I came across this document. In the UK and in Australia, and mental health being specialists and endocrinologists created a document on the importance of language, of how do you talk about diabetes to patients. And I was glad to see that Diabetes group from India prepared the version for Indian patients and healthcare professionals. So I would highly recommend you to check this link at some stage, because it's really important document, and really makes it to the point, how can we work with our patients. And just to finish this this presentation, one of the quotes from this this document was, I want my healthcare professional to be a friend more than a doctor. I understand that she will give me prescriptions and medical advice, but more than that, I want them to understand what I'm going through and not judge me for being a non-perfect type 1 diabetes. And I think it exactly explains what I wanted to present here, that yeah, living with diabetes is tough, and we cannot just focus on the numbers, because this pressure of being perfect sometimes is burdensome as well. And just to finish up, this is Teddy Ryder, one of the first patients who received insulin, and I just wanted to show you the letter that he sent to Dr. Banting. I'm confident to know that Dr. Banting was the one who discovered insulin, of course, he and his team. But this letter really makes it to the point of how it is to live with diabetes, I suppose. Dear Dr. Banting, I wish you could come to see me. I'm a fat boy and I feel fine. I can climb a tree. And this is what we should always remember when we speak to our patients. It's not about diabetes control. It's not about avoiding complications. It's about being able to climb a tree and to live with diabetes as best as we can. Of course, safe and trying to not to develop complications, but this is the key. So let's allow our patients to climb a tree, and this is where I would like to finish, and if there are any questions, I'm happy to answer them.